I wanted to talk about female pelvis from a chiropractic perspective, which I think of that as just a functional anatomy perspective. First of all, thanks everyone for coming. I had a really fun time thinking about this presentation, thinking about the diverse group of experts we have here. Kind of hard to talk to everyone from medical doctors to lactation consultants, physical therapists, but I'm hoping that everyone will get at least something out of this. This is my little family. That's my husband Luke, and Jacob is 3.5 and Giles is 1. And my dad's a chiropractor. I was born about 3 months before he graduated from Palmer in Iowa. I have a women's studies degree from Girls College in Oakland, which is kind of my rebellious phase. I kind of always knew I wanted to be a chiropractor, but then I had to do women's studies, but which actually completely informed the work I do now, and I absolutely love that practice. I went to chiropractic school here in Portland, so I was really fortunate to live here. And now I'm back in Nevada City, California, where I grew up and where my dad practices. So I get to work with him and work part-time and be with my kids and my husband, who we're going to be married 8 years this month. And I got to be born at home myself and have both my sons at home. The first one here in Portland, the second one in Nevada City. So, here we go. That way. All right. So, what's the root cause of dysfunction and pain? In old-time chiropractic, we look at the physical, the emotional, and the chemical. For the purposes of this talk, so physical, obviously physical. Emotional is more like stress-induced issues of pain. Chemical is food and environment and toxins, stuff like that. And for the purposes of this talk, we're going to look at the physical and biomechanical reasons for why we have pain and dysfunction. The first thing is lack of movement. So like something stuck in the body, stuck in the tissues. We call that hypomobility. The second is too much movement, which is hypermobility. And then the idea of a bone out of place, like, oh, I was out. So this bone out of place idea is kind of an old-time chiropractic manual therapy idea where they literally would take an x-ray and mark it all up and say, oh, you see the spinous process, it's rotated over to the right, so that must be the root cause of your dysfunction, therefore every time you come in, I'm going to adjust that spinous process right to the left and you'll be fine. Some people still kind of do this, but it is a older model. What is normal? So this is based on this idea that we have this perfect normal body like Leonardo's man. That doesn't really look like me, that doesn't really look like a lot of people. So we like to focus on function because there is this great variation between us as people and with our bodies. And so, for example, a person with scoliosis can have no pain, no dysfunction. If everything is moving well, all the joints are moving well in the body, they're perfectly normal, no pain. So we don't know, maybe that guy who was standing Leonardo's man could have had total low back pain because he had bilaterally locked sacroiliac nerve. Don't know. Looks don't tell us much. So movement is what matters. Where there's lack of movement, that's where we want to look. Life is movement. So where there's a lack of movement, like say here, say this ankle's locked in. What's going to happen is our body's a whole kinetic chain. It's going to cause these different rotations that go all the way up to the neck. So we have a lack of movement, something's stuck. And usually on the opposite side or just above it, we have hypermobility, too much movement. That's what causes pain usually. So as practitioners, we want to ask people where their pain is, but we want to then ignore that and kind of assume that that's a reaction to what the underlying cause is. The body doesn't want this hypermobility because it can lead, eventually it's going to rub the bones too much. Too much movement rubs the bones too much. It causes a breakdown in cartilage, and eventually that will lead to premature arthritis, osteoarthritis, and joint degeneration. So the body, in its infinite wisdom, says, okay, we have too much motion here, let's stop it. So first, what it does is it causes hypertonic muscles and spasm. That's super painful. Again, that's usually not at the side of the locked joint or the initial tightness. It's usually on the opposite side or just above. It will then actually lead to ligamentous changes and eventually tissue fibrosis of the area. So when we see all those great, anatomy pictures of scar tissue, that's usually what's happened. It's a hypermobile area that has gone too long. A disc herniation is a perfect example of a hypermobile joint. What's happened is, at the base of the spine, we usually get it at L5, the fifth lumbar. What happens is it's just been moved too much, usually because of some blockage down below in the pelvis. And so the joint, which is the cushion between the two, which is the cushion between the two joints, actually ends up bulging and then eventually herniating. So the issue isn't the disc itself, the issue is what caused that segment to become hypermobile in the first place. The body is so wise that eventually, after it does this tissue fibrosis thing, it will actually grow bone towards each other, which is what a bone spur is, and fuse the joint from a bony point of view. So here we have a perfectly normal spine. This is obviously a cervical spine, a neck spine. These dark spaces are where the intervertebral discs are. You can see in this normal person, you have that nice dark space. That's because the disc is still intact. In this person, we know that probably this is a hypermobile area. This is the bottom of the neck. It's like hypermobile in everybody because it's the transitional area from the thoracic spine, which is really supported well, the ribs and things like that, to the cervical spine, which has all these joints, tons of movement, and this freaking heavy thing on it. So you can see the bones here actually growing towards each other. That is a bone spur, or an osteophyte is a fancier name. And eventually when you see older people who have a lot of mobility, particularly women, you will see actual fusion of the joints. And then you have no pain. So our body is smart. Our body is smart in the long term. It's just in that process of hardening the tissues that's painful. So, what causes these hypermobilities and quote fixations? Oh, thanks. It's just one more thing. Structural issues. So these are things we're born with, like a short leg, a congenital malformation of the joint itself, hip issues, sacralization, which is where you have the bottom vertebra fused to the sacrum in some form, the bottom. Spondylolisthesis, which is a fracture in early childhood where the vertebra actually slides forward, and it's an occult fracture, it's called. You basically need an x-ray. Most people don't know about it unless we're treating them and we're going, you're not getting better, there must be something going on here from a bony point of view. You also have, history of injury or trauma, like a hard fall in the buttocks. This could be as early as, early childhood that could cause this. Car accidents with the foot on the brakes or the gaps where you get a, translation up into the sacroiliac joints, overstretching, etc. Repetitive microtrauma is something we do every day, a lot of. So, like if you're constantly doing this in a job, or you're constantly lifting, or you sit a lot, or you have just a little bit of a postural imbalance, a tight muscle that just kind of always pulls you to that side, that will eventually cause this imbalance. And then, of course, pregnancy, birth, and postpartum, which we all obviously love since we're here, where you have this natural hormone loosening, hormones loosening the joints that leads to kind of a general hypermobility, and then, of course, birth, which sometimes can really hurt women, especially in hospitals where they're confined to one position. Okay, let's see. If you guys need to stop me with questions, or if I'm going too fast or whatever, just stop me. So traditional manual medicine, chiropractic, osteopathy, things like that, looks at where the body's stuck and tries to mobilize it and soften that tissue. So this is why we adjust patients, or we do deep tissue like trigger point work, or we do traction. That works really well with the majority of the male population. But what I've found in my practice is that for women, it can actually be insulting. Not all the time, but sometimes. Especially with our pregnant and postpartum population where you have these big hormonal issues going on. Women tend to be just more mobile in their joints. We're made to have babies. And so we don't always get those really big fixations, big stuck joints. We tend to deal with more mobile joints, the interplay with hormones, and this monthly dance between instabilities and fluctuations in our tissues. So this is where it gets tricky. because from a manual medicine point of view, and this is something, like what I'm sharing with you guys today is, I didn't learn this in school. I didn't learn it in any of my seminars, I learned it in my own body. And, but you know, my dad taught me some of the releases that I'll teach you and stuff, and then just through my own research. And because most of manual medicine is unfortunately still male, it's kind of like the doctors finally coming out in the 90s and going, oh, actually, women have a different series of symptoms before they have a heart attack than men, you know? Whoops, didn't study women. Yeah. So this is, again, you know, something I've been finding. So this kind of general hypermobility happens for, you know, just biologically for us, physiologically, and then also it's really exacerbated by hormones. Relaxin, everybody knows about relaxin. Well, what I didn't realize is that like even men have relaxin. I thought it was just a pregnancy hormone until I started researching. And it peaks even in women who aren't pregnant just after ovulation and in the second half of the menstrual cycle. So for those of us who like notice, oh gosh, you know, my back's flaring up, and we kind of track it, it can really be because we have that extra relaxin in our system. And if we are prone to any sort of imbalance, it's going to be exacerbated at that time. So, like I get a lot of patients who come in, I was doing it, you know, the same thing I always do, but, you know, my back just went out. So, that can really lead to pain. So, even though with global hypermobility, which is kind of how I think of women in general, and some men, actually, I've treated some men who have the same thing, we still usually have a tighter side. So it's not like a traditional chiropractic locked joint, but in relation to the scheme of things, we still tend to have a tighter side. So that's what I really look for in my practice, and that's what I treat. So I just kind of think of it as like balancing this, you know, watery fluctuations, right, the best I can. So I love the pelvis. It's just awesome. So I always really work on balancing the pelvis. In pregnancy, postpartum, it's absolutely key, but for everybody, it's absolutely key to try to balance this as best as possible. There's really three major joints in the pelvis. You have these two sacroiliac joints. So there's one, there's two, here's your sacrum, here's your ilium, and your pubic joint. There's also the hip joints, but I'm not going to address those in this talk. And so this is a really important area because it translates all the way from the upper body to the lower body, and these sacroiliac joints are it. I mean, they really are. Something interesting that an orthopedic surgeon told me about once was when we were walking on all fours, you know, these sacroiliac joints weren't really weight bearing. They were kind of floating up above things, which probably led for a lot fewer low back problems. But when we became upright, all of a sudden, they are translating this weight from the upper spine to the lower spine and back, you know, the opposite way. They're kind of like these key, you know, just like the suboccipital area. It's this key area of translation and transition. So here's a picture of the sacroiliac joint. This again I love, right? Because in the old days, people thought, oh, those don't move at all. You know, we've looked at lots of dead cadavers and there's absolutely no movement in the sacroiliac joints, right? Just like the cranial bones don't move. So, not until like some chiropractors in the 50s and some other people came through, they said, actually, you know, look at these motion x-rays of a person walking on a treadmill, there's movement. And it's like 2 millimeters. 4 millimeters maybe, but it's there and it's, you know, in your body, just like cranial. You're like, it's big. You know, it might only be a few millimeters, but it's big. So the other thing is that for a long time, people never thought that this joint was a synovial joint. A synovial joint is a joint that has a sac in it, like around it, and then fluid inside of it, and so it pops. And there is movement there. Now people are going, yeah, there is actually a synovial joint, and it's half of the joint, this area. And then this part is where all the ligaments attach and doesn't move as much. So here's another picture of the sacrum. Again, this rough area is where all the ligaments attach, and then that kind of smooth area is where the fluid is, and that's where we have more motion. The sacrum is really key again in whole body balance, and it's my training, it's really linked to the sphenoid, where they say the ilium are more linked to the temporal bones. So if you find a really big sphenoid issue, check the sacrum. If you find a really big sacral issue, check the sphenoid. But if you're like me, pretty much everyone has those, so we'll see in business. Okay, so the other big joint is the pubic symphysis, which is right there. It's a non-synovial joint, supposedly, though I've heard them pop a lot too, so maybe that's going to be reclassified someday. It's anterior-radial, so it means it's a little bit of movement. And it's the big thing about this one is just like the front half or the back half of the synovial joints, it's really attached with a lot of ligaments. And those ligaments are really key in pelvic health. You know, I'm just realizing. Let's see how this goes. So, how does the pelvis move? And this is the part that I hope you don't glaze over. I kind of thought about how are we, should I talk about this? But I just think it's really interesting. And I'll try to make it simple. And if you have questions as I go, just ask. There's some really cool movable animations, like diagrams on this Sorolla website that I was going to pull up, but I might not since the website, like the computer's way down there. I might just talk you through it with the spine. But if you want, you can go look at those later. So the sacrum moves forward into nutation. So here's your sacrum. When it moves forward like this, that's what we call nutation. When it moves backward, that's counternutation. It's pretty simple. There's only two things to remember. Now, when it gets a little bit trickier when you add the ilia in. When the sacrum moves forward, the ilia comes back. When the sacrum comes back, the ilia comes forward. Not too bad. Yeah, those are really cool animations, but we just won't pull them up here. Okay, so again, this is a little bit trickier. We call, for the purposes of classifications and talking about pelvises, we have names. They're called listings. Physical therapists and chiropractors. So when the ilium, so this is posterior ilium, PI. When the ilium rotates back, so again, that sacrum would be coming forward into nutation. We call that a PI, a posterior ilium. It is based in these posterior superior iliac spines, basically the sacroiliac joint right here. So again, this comes back posterior inferior, PI ilium. The sacrum goes into what we call anterior inferior. It will come forward at that same joint. So just remember these are supposed to move opposite. And it's easy because it's PI, AI. Then the other side, so then the other malposition, we call it, is anterior superior, right? The ilium's coming forward anteriorly and superiorly, and the sacrum would then be coming back posteriorly and superiorly. So you've got your AS, PS pelvis. Is that okay? Okay, cool. You guys are good. So this is kind of, and this is why I gave you guys slides. I wish they would have given us something like this in chiropractic school. They never did at my school. They do in other schools. But this is a really cool way, if you ever do get to look at an x-ray, it's really easy to see, again, what this person is dealing with. So when you have a PI pelvis, this is on the right side, the ilia looks more narrow, and this guy, the obturator foramen, is taller. So this is an android pelvis. This is what a male pelvis looks like, which is why it's important to balance pelvises before people have babies, because if somebody's locked into that or has a tendency to be in that PI pelvis, both sides or one side, they're going to narrow their pelvic outlet. So that's one of the arguments for manual therapy during pregnancy. So here is a double AS pelvis. So you have both ilia rotating forward. So we're going like this. The sacrum's coming back, and these little holes, the obturator foramen, are getting less tall. So this is what a female pelvis tends to look more like. Are we okay with that? You also have an increase in lumbar curvature with this setup, which is kind of like when you look at most women and we're like this way back type, right? So, but that's because of this configuration, there actually is kind of you can make sense of it. So here we have a typical android pelvis where you have the narrowing of the ilia, the wider obturator foramen, and again, it's rotated back into a bilateral, both sides, posterior, inferior, PI sacrum, PI ilium. So here's the female. You get a much better pelvic opening there. So this is kind of some fun things. If you have, so that's just what I've already said. The PI and the AI go together. The PS and the AS go together. You tend to, if you are kind of try to self-diagnose like I do all the time. So these are kind of some tricks of the trade. You usually stand heavy on your short leg, right? Now, if your ilium is rotating backwards like this, that leg's going to be short, right? Does that make sense? I should have put a slide in on for this one, but so here's your hip joint, right? If your ilia comes back like this, you can just imagine that leg is shortening. When it comes forward, that leg is going to lengthen. So, so that tends to be your short leg you stay heavy on, which is your PI side. Which some of you might be like, oh, I wish I'd heavy on this side, or you know. You usually cross your leg of your PI side, and your psoas tends to be tighter on your anterior superior side, and the PI side or the AI side tends to have the tighter sacrotuberous ligament. From craniosacral people point of view, like, you know, we kind of treat what we find, but I really like going into my treatment informed about kind of what to look for too, because I don't know, I guess I'm just kind of clinical like that. Okay, so let's look at some other players with the pelvis, right? So we have the joints, which as chiropractors we're like the most excited about first. But then we have these ligaments, which with kind of the global hypermobility syndrome actually are really, really important. They're kind of like the tethers of the pelvis. So if the pelvis is a circus tent, they're like the ropes holding it down, and they kind of let it move a little bit, and they guide the motion a little bit, but for the most part, they really try to keep that tent standing. The muscles, of course, just move the joints, and the fascia connects and interweaves it all, and holds everything together. So again, treating fascia is awesome. So my very two favorite ligaments in the pelvis are sacrotuberous right here, and sacrospinous, which is here. So right there. And I love this picture here because you can see how everything really is suspended, you know, in this configuration of being upright. But so here's your sacrospinous, and here's your sacrotuberous. Not only does that hold in your whole pelvic floor, but these are absolutely key in pelvic health. I have another picture because they're so cool. So again, sacrotuberous. It goes from the sacrum to the ischial tuberosity. And here's the sacrospinous, goes from the sacrum to the spinous process there. What's that called? I'm facing it right now. Sacrospinous. Is it the I'll think about it when I'm not giving a talk. So again, especially the sacro, talking about correlations, it's kind of fun to note that the sacrospinous and especially the sacrotuberous ligament, but both of these really correlate to the suboccipital muscles. I had a really fun experience when I was shadowing my dad before I went to chiropractic school, and this woman came in totally dizzy. She'd been dizzy for days. And he came and he put an elbow in the sacrotuberous because he didn't find any restrictions in the upper neck, and just sat there for a while, and then she got up and she wasn't dizzy anymore because her upper neck released that quick when they just balanced it from the bottom. There's actually a whole chiropractic technique based on this ligament called the Logan Basic, where they can hold it for like 7 minutes. You know, it's pretty cool.
It's just a sacrotuberous
ligament.
Just a sacrotuberous.
Well, there's some other stuff, right, that you do.
That's interesting.
Yeah, but I just think that's interesting because it's such an important ligament. You know, there's a whole technique of it. So, let's see. So another key player I always look at is the psoas muscle, and probably everybody here is familiar with that. It attaches onto all the lumbar vertebrae on the front and sides. This is a pretty good picture of it. But it also attaches up to the thoracic vertebra, which most people don't really know about. And the other thing that tends to happen too, and I got to see this in a cadaver lab last year, which was awesome, but the psoas minor actually comes down in, and it actually attaches more on the pubic rami. So it can really be an issue with pulling the pelvis out of whack. Yeah, and you might palpate that. Sometimes I think people get it confused for the round ligament, but it's really the psoas minor. But a lot of people have, again, you know, just like the sacroiliac joints and the upper neck, this thoracolumbar junction is a really big issue for people. And a lot of times when you have pelvic, this area can refer pain to the groin, to the sacroiliac joints, and to the hip joints. So if you're treating somebody's pelvis for a while and they're not getting better, you know, look up. And a lot of times this psoas can spasm and do all sorts of things, and when it does, again, it pulls us into this hyperlordosis. And a lot of times in women, because we're dealing with this kind of global hypermobility, it's really just a psoas issue, you know, and so you release their psoas and they immediately feel way better. So it's the second strongest muscle in the body after the masseter, which is pretty cool. It's the sit-up muscle, so again, if people are doing like the old-fashioned sit-ups, where you really pull yourself all the way up, you're strengthening your psoas quite a bit, and again, that can be a detriment to the pelvis. Yeah. Oh, yeah, and then you kind of keep it chronically tight. So things that tight, its main job is to lift the knee. So anytime we hike, we walk upstairs, we sit for a long time, it shortens. And the best, you know, it's hard to stretch by yourself, but we'd give people this knee on the stool stretch, or, you know, knee to opposite shoulder laying on your back, and that can get into there. But again, if anyone knows a stretch that's like really good at getting the psoas, besides this, I would love to know, because for the most part what I found is the best way to do it is just put manual pressure on it. But it'd be great to be able to